We have an idea. The whole idea behind the Improvement Showcase is that what if the big idea was actually connecting a lot of small ideas. And really this is about partnering and collaborating, sharing, learning from each other, and starting to build a community around great ideas, but also helping each other learn from each other so that we can not make the same mistakes and deliver amazing projects. There's a lot of amazing things happening in South Australia, and we're really keen to celebrate that. My name's Tina Harden, and as the Executive Director of Clinical Informatics, I was really keen to have a series as part of this showcase that focused on data in action. How do we deliver actionable insights to clinicians, to the community, to people who need to make decisions on the ground? So we have an amazing series of presenters coming up. This is a quick little plug for on the 20th of May, we have Rosie Tiramaku, who is the Operations and Research Manager for ICCNet, and her talk is Improving Cardiac Outcomes in Country SA. So she invites you to come with her on looking at the 20-year journey of ICCNet SA, implementing and evaluating innovative solutions to improve cardiovascular disease outcomes at the population, local health service and individual patient level in regional and rural and remote South Australia. This program has earned national and international recognition for its amazing achievements. And on the 27th of May, we have Associate Professor Rosanna Tavella, the Clinical Data Manager in Cardiology at the Queen Elizabeth Hospital. Her presentation is Coronary Angiogram Database of South Australia, CARDOSA, a nexus between clinical research and health service delivery. So Rosanna's going to talk about how the program looks at three components: a clinical quality registry, patient-related outcome measures, and an integrated blood and tissue biobank, which enables the assessment and monitoring of procedural safety, performance appropriateness, as well as evaluation of patient-centric quality of life outcomes. So that'll be a truly exciting talk, and Rosanna's been really at the forefront of clinician engagement and really working with clinicians to have data in action. But today, our speaker is Dr. Andre Andrade. He's a Senior Research Fellow with Digital Health in the University of South Australia, Clinical and Medical Sciences. His talk is Precision Public Health Going Digital, and he's going to talk about digital technologies that allow us to create public health initiatives with high precision, even at a large scale. And just a reminder that our Improvement Showcase series is Thursdays at 1 o'clock every week, or online whenever. As we said, these are recorded, so you can always jump online to see the recorded versions. We're about providing bringing healthcare teams together and providing a space to explore what others have learned. We encourage people to keep it simple. And as I said, the format is 2020, so 20 minutes of a presentation with the opportunity at the end for question and answer, which is not recorded. So we invite you to come and tell and share your story with us. Have you got a problem that you've solved? Have you learned something whilst trying? Do you have themes you'd like to be explored? Please come and join us. I've already had a bit of a sneak peek at the series for June, and I can tell you it's going to be a cracker. So we encourage you to follow us on LinkedIn and follow us on Eventbrite so that you can stay tuned and continue to be part of this showcase series. But right now, enough from me. I'm going to hand over to Andre, Dr. Andre Andrade, for his presentation. And welcome, Andre.
Thanks, Tina. Let me share my screen here. Right. So thanks, Tina, for the presentation. My name is Andre. I have a background in medicine, but my métier is digital health. And my goal today is to talk about how the Veterans Base, which is a precision public health, and I'll explain a little bit how it works, how it uses data and digital technologies to change clinical practice. And I'll be focusing on our experience like 2 years ago of changing what was already a very successful intervention into the digital world, digital media. So my plan here today is to talk about three things. First, just explain what the Veterans Base is, what it's been doing for the last 18 years. Talk a little bit about the e-delivery project, and then show an actual case study of how we use data to change actual practice, to make this more palpable, more real. First, with the Veterans Mates program, it is a data-driven precision public health program providing up-to-date health and medicine information specifically tailored for members of their veteran community and the healthcare team. It's important to highlight here that it is not only about medicines, but it's quality use of medicines. So it's actually about therapeutic choices that may mean ceasing medicines, introducing new medicines, or actually searching for different ways of treating the different conditions. It's a very broad understanding of this concept, and it's important that it's not only decision support; it's really an intervention to change population health. It's not just a decision, but a long-lasting effect. It's been funded by the Australian DVA since 2004. It's a collaboration from UniSA, UniAdelaide, the Australian Medicines Handbook, the Drug Therapeutics Information Service, NPS, and HealthLink. So it's a huge consortium, and again, it's been going on for a long time. And when I say precision public health, I know that it's a bit of a buzzword and it's kind of tricky, but the goal, I think it applies well here. The idea is to get a huge amount of data and try to distill this amount of data into specific recommendations for individual people. So there are three main areas of expertise. The first one is just to identify healthcare issues and trends. So there is, say, Aged Care Commission or a commission on top campaign or new medicines being added to the market. This triggers an investigation. Then we look at the huge database, we're going to talk about this a little bit later, to search for the trends where there is a clear problem we can identify. Once this has been identified, we pinpoint those who would benefit from the intervention, those at risk for either a problem or where the prescription pattern of an appropriate prescription pattern has been going on. And then we create an intervention to provide individually tailored recommendations. So it's a different recommendation for each person according to their needs. And on the third step, we measure the impact of the intervention using, again, the same initial database. So what's this database? It's the Australian government, DVA, routinely collects health claims data. It has been growing since 2004. It's now over 1 billion different health claim records of over 16 years of actual data with 10 years of historical health data. So it's very comprehensive. We have hospital data, including diagnosis, everything that basically happened during this hospitalization, the procedures and diagnosis. We have a complete record of the pharmacy and medical and allied health records, and I think the pharmacy one is particularly important for us. So we know everything that's being prescribed, when it was dispensed, how often it was renewed, the prescription was renewed, and basically every service that's billable to DVA, which is almost everything. So doctor visits, radiology, pathology claims, everything that's claimed to DVA, we have in our database. And whether the client data is updated weekly, health claims data are updated monthly. So it's pretty, probably 2 weeks lag at most, in most cases. Perhaps hospital, there's a little bit more lag, but it's pretty up-to-date information. And we make use of this up-to-date information to actually respond as quickly as we can to identify the issues. So it's probably about 2 weeks lags in most cases, hospital about a month lagging data. So it's pretty up-to-date. And I think also it's important to say that not everything we do is data-driven, but also it's behavioral theory-driven. So this sets us apart to the decision support system. It's really not only decision support. We want every intervention to be long-lasting. There is personalized information, but it's always, there's an underlying theory of the social cognitive theory and the trans-theoretical model. The social cognitive theory basically says, it tries to explain how people learn, whether they model their behaviors according to whoever they are observing, whether they find their self-efficacy to create a new behavior change, whether they think they're capable of doing something different, whether they intend to do it, and whether they think the outcomes will be good. The trans-theoretical model basically says that we have 5 different stages of changes, and we move across these different stages from just thinking about different behavior to actually enabling and realizing it every day, readopting this different behavior. And again, not decision behavior. Some of the things like prescription will be not only for this patient, but from now on, when there's a different patient, how will you behave? And also it says that we have to talk to the veterans themselves about how they should, for instance, treat their pain or treat their usually non-medicine or conditions where medicine is not very so good, such as depression, for instance. And it's important for the veteran to really understand how they can become self-efficacy to do something, to treat their disease better. And so how does this go into practice? This is very abstract, but this means that every intervention, we do 4 interventions every year. It's a multimodal intervention. So there's basically 2 components. The first one is education for health professionals and veterans. We create something we call therapeutic brief, which is a summary of evidence on a given topic. So I'm showing the example here for pain and gabapentinoids. The GP document is basically focused on how what are the indications of gabapentinoids in pain, what is the evidence behind it, what are the non-medicine approaches to pain, how you should review, how you can plan strategies with your veteran patient, and how can you become more able to perform this from now on. And the veteran one is actually how can you recover from pain? So it's not only about prescription, but it's actually about the problem, how they can use strategies that can help pain. And this means usually how you can think about your pain, how you can think about your reaction to pain, how you can search for allied health professionals, and how can you talk to your doctor about it? How can you explain what you're feeling to your doctor to improve the strategies that you are going to perform to improve your pain? So this is one component. It's really education-based, heavily evidence-based, but also very theory-based, behavioral theory-based. And on the second one, which also again is something that distinguishes this program, it's an audit feedback document. It's one document for each patient. We basically make a review for medicine that has been on for the past year, past 5 years, services that are related to this issue. And this is mainly to create this reflection idea that the GP reflects on the prescription to think whether it's appropriate or not. So we're not really, we expect GPs to be completely autonomous. It's to be useful for them. It's to provide different information, additional information to what they have, and then provide recommendations based on what it seems to be according to the most appropriate behavior. But again, it's the GPs are completely autonomous to make whatever decision they want, and we incentivize this. This is a very good thing to do. We don't want something to be just for this patient, but something to long last over time. And this is in a nutshell the Veterans Mates program. I'm going to talk later on a use case, but now let me get this to just talk about the C-Delivery project. So from 2004 to 2018, this program was, again, data-driven, but interactions with GPs and veterans was basically post. We created the printed materials and sent them by post to GPs and veterans. This had 2 major problems. The first one, it's very effective. There's no doubt about it. We have demonstrated several times that it's very effective, but it's not as agile as we expect to be. Particularly given we just have 2 weeks lag, and maybe it takes that much just to print materials and another time to send materials. So it doesn't really make sense this time just to logistically make this doable and national scale. Didn't really make sense given the digital capacity we have today. And the second goal was to incorporate this into GP's workflow to become more embedded in their daily lives. And this was kind of my mandate when I came here 3 years ago. It's very clear that there is a clear opportunity here. We know that most Australians have a GP, they see GPs every year, and they have a preferred one. So it looks safe enough to send something directly to one GP, because it's probably the main care provider. And there is a very high likelihood that the patient will return to this same GP. And Australia is unique in this in the world. It has near universal health record use for more than 10 years. This is a paper from 2008 showing that more than 90% of GPs had been computerized in their offices. So the opportunity is very clear here of the digital infrastructure. However, when I came here, it's a very broad mandate, right? Just use digital technologies. And this basically was our guiding principles. How do you create something that follows the determinants of innovation theory, that Chris Greenhalgh's theory, basically saying that you are more likely to get innovation approved when it's a little bit better than what you had before. When it's compatible with current process, you're not requiring people to totally change the way they work. There is low added complexity, particularly for the end user. We don't really care about how it's complex for us. It's about how complex it's for the end user and how complex it is to actually implement something. Whether we can trial whatever we're doing differently, and this is very important, particularly for GPs, I think, and for doctors in general. It's not only resistance to change, but the responsibility is so high, so great, that it's important to start small and be able to really be sure that what we're doing is not creating harm. So no harm is the Hippocrates stuff. We need to follow this. It's very important for us. And also strategies for risk mitigation. And finally, and I think this is one of the main lessons for us, is that stakeholder participation is essential. So whatever we're doing, and this dates from 2004, has DVA approval, RCGP approval, consumer approval, NPS approval. Every inter-stakeholder involved in the project must be totally understanding what is intended, how is the process going to be, and what is expected to happen. And so it's very important for us to have stakeholder participation. So just some challenges. The first attempt we had to try to do something in digital was the population health management software. Basically, patient lists with lists of problems, and then the GPs would be able to explore further data. This didn't work really well for us, given that the geographical distribution, some GPs just have 1 or 2 veteran patients. So it's very heterogeneous in terms of what's our main audience. And then we went to data integration engines with a lot of flexibility, because every topic is different, even if it's slightly different, it is different, the goals are different, and it's very theoretical based. So the way we provide information would be always a little bit different. And we faced the first problem, that it's the market that does not go to product orientation, but rather service orientation, but rather product orientation. So there is something, and they just want to install this something and charge for maintenance fees. And this didn't really work for us. So what we did is try to develop technology in-house. I was not a very big advocate for this before, and it worked for us. I think in the specificities of the program, it's something unmatched in the world. I don't know any other product that does what in national scale. So that's also one of the reasons why we needed to do maybe something more customized than the average user. And the technical solution we decided was to go secure message infrastructure way. So the workflow is basically the same as before. We still use health plans to generate patient-specific data, but then instead of mailing this, we create a data-driven document as a PDF document. We encrypt it as a health link, health level 7, AHL7 document, as a referral document. We encrypt this message, and then we forward it to GP in the same way they receive laboratory results. They see this as a letter in the inbox, as it looks like a referral, and then they can choose to action on it, archive, do what they would do as an actual referral document. And within this document, we then provide links for them to go to educational materials, to print educational materials, and go forward on the intervention. Our big concern was, okay, we're sending unrequested documents directly to inbox, so they really can't avoid us. What's going to be the fallback from GPs? So we started really small, 5 people in the first module in 2019. Our team very carefully evaluated. We just called the GPs directly, saying what we're going to do, ask them feedback. On the second one, we went to 20, then 189. Then on 2020 first, we did the first actual clinical trial. So this 1,600 GP messages was actually part of the clinical trial. But then when COVID hit, we were ready to respond very quickly. So we quickly scaled to 51,000 messages in a couple of weeks. And I think that's the main advantage of going digital, is this capability of scaling dramatically and very quickly, and evaluating all the way, having data just to create the interventions, but also to measure whether they make a difference in the end. So I'll just exemplify a bit with a case study, and this will be the gabapentinoids case study. I'll try to be very brief here, but again, 3 steps: identify, create intervention, and then measure intervention. To identify the problem, this is the picture we had in 18. From the red line is the gabapentin dispensing rates, and the yellow line, orange line, is the pregabalin dispensing rates. You can see that there's a huge bump. And there were several indications that or a significant proportion of these pregabalin prescriptions were not for epilepsy or neuropathic pain, but actually for non-neuropathic pain, which is not a proper indication. Also, we found a large number of physicians with high dose or low dose, which would be ineffective. Then we create this intervention. So on the left side, there's the educational material giving practical information, and on the right side is the actual intervention. So we can see that this is a data-driven document. We use colors, we use charts, use prompts, we use recommendations. There's a clear anatomy for everything we do. Everything has a reason for why they exist. Rationales. It's all based on behavior change theories. And all there is for all of this, there is some kind of prompt or some kind of theory behind it. And these are the main results. It was a bit of an unfortunate time. It was really the week after COVID restrictions started. So we were a bit afraid that this wouldn't have the same effect as the other ones, but it clearly had. So we saw a 13% reduction in gabapentinoids prescription, and this was sustained over 6 months. So it was clearly effective. This is for the whole population. As I said, this was a randomized controlled trial. We divided in 2 arms: the conventional treatment by post and delivery with the digital distribution of materials. And as you can see, both lines were equally effective. So they both had this approximately the same effect, which was, I believe, for us, we can show we can proceed safely. And this, and we can actually keep improving, because this is one of the main advantages of the digital. We can actually trial things very fast and change the ways we provide information, change the ways that the feedback, the audit feedback is constructed, so we can iterate and can test things quickly. And now it's safe to do it because it's been proven as effective as. And this is for psychologist visits. So we could also demonstrate that not only the medicines were less prescribed, but the adequate search for services, mental health services, was improved. And again, this was still lasting for 6 months. And as you can see, the blue line, which is the digital delivery, was even more effective after some time. We believe 2 things. At first, that since it stays with the health record, it keeps its effect for longer. And also it's more easily actionable. It's very easy to just press a button in the health record, say, please call this patient, let's do something for him, let's refer. So there's still a lot for us to learn. We're still progressing this over the last few months to understand exactly which topics and the way we have to structure information to make this more effective. Finally, for lessons learned, it's pragmatism at first. So do not reinvent the wheel, just try to see what you have embedded in your already existing infrastructure or your advantages, and then build upon your disadvantages. Innovation, you always have to think innovation not only as a discovery, but also enhancing what is already highly sophisticated, in our case, the algorithms and the behavior change techniques, but using digital medium. And finally, collaboration. This couldn't be possible without 18 years prior. It's a long-lasting collaboration, and it's been wonderful. Without this would be impossible. So that's it for me. Thank you and welcome the questions.
Yeah, thank you so much, Andre. That is a fantastic presentation and a great way to kick off this Data in Action series. I really want to thank you because we didn't give you that much time to prepare for this, so we really appreciate that. And we thank everyone for joining us in this conversation. We will now just stop the recording, and we will then open up the